And we're all set
We
up.
are live.
All right, it's the pre-show. Barb, we see your box there, Elizabeth.
I think that will disappear momentarily.
All right.
Oh,
Change my view so I can see everyone. I'm going to start right at 6.
oh, shoot.
Mark, how you doing?
Okay, we have 33
Good.
attendees already on.
Sorry, I was a little late. You know, I always come about 5 minutes early. I should have checked my
Mark,
phone.
we were all here at 5:30 waiting for you.
You were here at 5:30, so
Well, we were supposed to be.
Okay, we have 35 people online and they can hear everything we're saying.
That's all right, I knew. It's probably 35 of our friends.
Mhm.
All right. We think our hour will go quickly.
Mhm.
Exciting.
And we are now live on Facebook as well.
Great. Thanks, Ian.
You're welcome.
All right, 2 more minutes. I have 1 minute to go. Cheryl, I saw your question. The answer is yes. I'm pretty sure. Yeah. All right. And here we are. So welcome all to tonight's panel discussion to discuss COVID vaccine history, ethics, and epidemiology. My name is Carrie LaPlante. I'm a professor and chairperson in the Department of Pharmacy Practice at URI, and I currently serve on the Governor's COVID Vaccine Advisory Committee and truly honored to moderate tonight's discussion. So with the arrival of the COVID vaccine in December, about 6 weeks ago, people across the country and around the world began to feel hopeful that we may be able to see a light at the end of this tunnel. But the end is not here. just yet. You know, between the arrival of various vaccines and the possible eradication of the disease itself, the new variant that's out there, there's just still so much for all of us to do. And I just checked a little while ago, as of today here in Rhode Island, we administered over 56,000 doses over the past 6 weeks. Before we dive into this, let's take a brief step back and think through, and that's where our first panelist will come in. What does history tell us about our previous mass vaccination efforts throughout America? You know, and as we move forward, let's discuss who gets the vaccine and when. And we have an ethicist on here who's going to help discuss how to prioritize different populations and the framework we're going to use to discuss who gets the vaccine and when. URI has assembled an interprofessional team of experts that can provide their expertise and insight. We have very different perspectives, and we're excited for this session tonight. A bit of housekeeping first. The format for tonight's session, we intend it to be a community conversation. We have hundreds of people pre-registered. We're very excited about that. It's a virtual conversation, and audience members may pose questions using the Q&A session on the virtual platform. We're going to try to get to as many questions as we can, but with hundreds of people on here, I realize it's going to be a little challenging. I have a 3-person team. They're all behind the scenes working to send me these questions. And again, we'll do our best to address these, you know, efficiently and the best way we can. Having said that, we got some questions in advance of tonight's discussion, and a lot of the questions can be easily answered by the Rhode Island Department of Health website, which has been fantastic. So if you have any general information questions, please go to the COVID website and information on the vaccine rollout. We have a slide there, you can see it, with the phone number to call in the website. Please refer to that for any specific questions that you may have. So with that, let's get started. You know, as of Tuesday, the United States has reported at least 400,000 deaths from COVID-19 since this terrible pandemic began in March. And they say that's more than the numbers of Americans that died in World War I, the Vietnam War, and the Korean War combined, and nearly as many Americans who died in World War II. There are significant health, but also social and economic impacts from this global pandemic that we're going to be working through for years to come, maybe even decades. You know, we're going to discuss some of these complexities this evening. I'm going to give a brief introduction of all of our panelists, and then we're going to start our first round of questions. So with that, I'm honored to introduce our first panelist. It's Professor Andrea Rusnick. She is here at URI in the history department. She's a historian of science and medicine. Could wave, Andrea, so we see you there. She's the author of 2 books and numerous articles on 18th century medicine and science, and she's currently finishing a new book on the history of smallpox, inoculation, and vaccination. She received her BA from Brown and her PhD from Princeton. Welcome to our panel.
Thank you.
Next, we have Dr. Phil Chan. Dr. Chan is a medical director at the Rhode Island Department of Health. He's been involved with the COVID response effort in Rhode Island since the beginning. We often see Dr. Chan next to the governor and Dr. Alexander Scott on the weekly COVID communications. Welcome, Dr. Chan. I know when we chat, you're going from like 7 a.m. to 9 p.m. every night. We thank you so much for taking the time tonight. Next, we have Professor Mark Hutchison. Professor Hutchison is department chairperson in political science at the University of Rhode Island. He's spent his career researching trust in government authority and institutions through the analysis of national surveys in the US and across the world. His interests in political trust lead to research in public health, focusing on examination of attitudinal barriers to vaccines across disparate patient populations in the United States, work that Professor Hutchison and I have done together. His research has been published in the Journal of the American Pharmacists Association, the Handbook of Political Trust, and the American Political Science Review, and also the Journal of Politics. Welcome, Professor Hutchison.
Thank you.
Lastly, we have Professor Cheryl Foster. Professor Foster is a Carnegie Professor of Philosophy at the University of Rhode Island, where she teaches and writes on natural and environmental philosophy, health ethics, and experiences of war. She enjoys working with first-year undergraduate students, passionate educator. She enjoys working with military veterans and healthcare professionals, students from diverse backgrounds, and those whom higher education is a new experience for them. I welcome our expert panel. And again, I thank you all for your time this evening. So it makes the most sense to start with a historical perspective on vaccination. So the first question is for you, Professor Rudnack. Let's open our discussion and think, as a historian of vaccinations and their impact throughout history, most of us knew little about. I myself knew little about the history of vaccination over time. Most of us get vaccinated against a number of illnesses, but very few of us remember a pandemic that has required such a worldwide response. Can you tell us about vaccinations that have been developed and how they've been adopted and how they've made a difference?
All right, thank you so much, Carrie. And thank you, Elizabeth Roberts and the Academic Health Collaborative at URI for inviting me to participate in today's forum. What I'm going to try to do is give a very quick overview of the roughly 300-year history of vaccination and highlight some of the questions that Carrie just raised. Let me begin with some numbers. In 1850, the average life expectancy in the United States was 40 years. Today, it is 80. In the last 150 years, we have effectively doubled life expectancy. And there's several factors to account for this. Higher standards of living and better nutrition are important, but the key factor is the decline in deaths caused by infectious disease. And vaccination has played a key role in changing our disease environment through disease pains and through routine childhood vaccination. The origins of vaccination stem from traditional practices to prevent smallpox that were found in many cultures, including China, India, West Africa, and Turkey. Individuals deliberately infected themselves with smallpox through a small scratch on their arm, and the resulting disease was usually milder than natural smallpox. And importantly, it gave lifelong immunity. European travelers and colonial settlers became aware of this practice, which was called inoculation, and it gradually became adopted by doctors and surgeons during the 1700s. At the end of the 18th century, in 1798, the English doctor Edward Jenner introduced an immense improvement by using cowpox, a milder disease that provided cross immunity to smallpox. Jenner's innovation became known as vaccination, after the Latin word for cow, vacca. Smallpox vaccination spread rapidly in the wake of Jenner's work. The Spanish launched an ambitious 3-year mission from 1803 to 1806, bringing the vaccine to its colonies in the Caribbean, Central and South America, and the Philippines. The British sent supplies of vaccines to correspondents from Newfoundland to India. In the United States, the Rhode Island doctor Benjamin Waterhouse was the first to try vaccination in the young republic and worked with Thomas Jefferson to encourage its use. Supply chains, however, were fragile, and many communities lost cowpox and had to wait for a new supply to renew vaccination efforts. For the next 80 years, smallpox was the only human disease to have a vaccine, until the French scientist Louis Pasteur created one for rabies in his laboratory in Paris. Pasteur named his product a vaccine to honor Jenner, and this is why we refer to all immunizing agents as vaccines. Pasteur, along with the German scientist Robert Koch and others, pioneered the modern sciences of bacteriology and immunology. And around 1900, scientists developed vaccines against typhoid, tuberculosis, and diphtheria, all bacterial diseases. After World War II, with the emergence of virology, scientists created vaccines against polio, measles, mumps, rubella, the flu, to name some of the 28 human diseases that have vaccines available today. These vaccines have been used to control outbreaks, but they've also been used in more systematic ways. After World War II, the World Health Organization launched the Smallpox Eradication campaign, which depended on the cooperation of the US and the Soviet Union during the height of the Cold War. The campaign worked by identifying outbreaks around the globe and vaccinating exposed individuals. Its success, smallpox was declared eradicated in 1980, is powerful testimony to what can be accomplished by humans on a global scale. Prior to its eradication, smallpox killed 300 million persons in the 20th century alone. Smallpox remains the only human disease to have been completely eradicated. Polio has also been targeted for eradication through vaccination. Launched in 1988, the Global Polio Eradication Initiative has reduced the incidence of polio by 99% through ongoing vaccination programs. And this too is a huge success. In addition to these global campaigns, routine childhood vaccination since the 1960s has substantially lowered infant and child deaths due to infectious disease. Diseases that were once common, measles, mumps, polio, are no longer part of the disease environment. There's an important caveat. Not all diseases have a successful vaccine. Efforts to create a vaccine against HIV/AIDS have failed, as have attempts to create an effective vaccine against malaria. We have to rely on other public health measures to lower the incidence and mortality associated with these diseases. So we've been very fortunate with the rapid development of several vaccines against COVID-19. The challenges we face now, getting vaccine supplies to affected populations, remain as pressing today as they have in prior vaccination campaigns. The realistic goal is to use vaccination to control COVID-19, much like we use the flu vaccine to control flu outbreaks, but coupled along with the tried and true methods of social distancing, surveillance, quarantine, and isolation of infected individuals. Thank you, and I look forward to your questions.
Thank you. I realize that was probably nearly impossible to give over 100-year history in 3 minutes. You did fabulous. Thank you very, very much.
Thank you.
All right, next up, we have Dr. Chan. Dr. Chan, you know, we've been watching you. You've been instrumental in Rhode Island's COVID efforts since this began. You know, in addition to all the hats you wear, you're also working on the Rhode Island's vaccination program. You know, in these thousands of hours that you have spent embedded in helping Rhode Islanders, you know, share with us what's the most important part about this effort and what's been most challenging to you?
Yeah, thank you, Carrie, for hosting, and thank you to Elizabeth Roberts and URI for inviting me, and thank you all for attending to listen. So, great question, Carrie. It feels like 100 years, even though I'm reminded it's not even been a year yet since our first case. Can you all see my slides on the screen? Sounds good. So just real quickly, I have like 3 slides. I promise it won't take that long. So goals and challenges. So, you know, I'm very interested to hear about tonight's discussion. I think one of the challenges that I'll mention in a second is about prioritization, but very early on, we here at the Department of Health have developed and approached vaccine implementation based on these 4 general principles. And these have guided the effort. And I think it's important just to put this out there because a lot of what we do, and others, certainly the panel, other questions, people from the audience should feel free to comment, but these have been our 4 guiding principles. And just to really briefly review here, number 1 has been safety. And there's been a lot of concern that this vaccine was rushed. Again, it takes on average 8 to 10 years to bring a vaccine to fruition. But I just wanted to reassure folks that this vaccine has gone through all the rigorous protocols and review that any other vaccine has gone through. And as Dr. LaPlante mentioned, there's actually a vaccine subcommittee formed by the state to review in part the safety, the science behind the vaccines to make sure that Rhode Islanders in general, it's safe for Rhode Islanders in general. So thank you, Dr. LaPlante, for serving on that. So safety is very forefront in our mind, and I'll chat a little bit more about that. Secondly, and I think importantly, as we talk about prioritization, we want to minimize morbidity and mortality, right? The entire goal of a vaccine, in part, is to reduce the number of people who are affected, infected for sure, and obviously those get severely ill and die as a result. And in thinking about this, the groups that we prioritized, we started off with healthcare workers, as well as individuals in nursing homes, assisted living residencies. Again, here in Rhode Island, as in much of the country, but here in Rhode Island, we've seen about 75% of deaths among our nursing home population. And so definitely understanding that we need to prioritize our older population and those that have other comorbidities. And importantly, also the healthcare sector. So I'll remind people that one thing we've seen in other parts of the country, as well as the world, that people die because they're obviously infected with COVID. But the other reason that people die is because the healthcare system gets overwhelmed and can't provide the needed care to people who get sick. And so protecting our healthcare workforce has been critical to ensure and reduce morbidity and mortality. Thirdly, and I just want to highlight this as well, that the efficient distribution of the vaccine, right? So one question that often comes up is, have we wasted any doses in Rhode Island? And so I can safely say that no, we haven't wasted any doses in Rhode Island. And that's part of the reason why it's been a bit of a challenge in terms of planning and logistics. Some of you may have gotten a sense of this in the media, but essentially we're at the, we're at the mercy of the federal government, the supply coming in. From day to day, we don't often know what we're getting, certainly from week to week, from month to month. It's been one of the themes of the pandemic, both in terms of PPE and testing and pretty much everything else. And we've had to be flexible and nimble, and really that's led to some long nights, frankly, in terms of having to plan and get stuff done. And finally, the fourth guiding principle here is equity and to maintain access for all Rhode Islanders. Some of the things that we've done here in Rhode Island that have received a bit of attention include prioritizing vaccine for residents of Central Falls. Some of you who have followed the data know that Central Falls specifically has been very hard hit by the pandemic. In fact, they're really, if you look at the data, it's astounding. They've been above and beyond any other town or city here in the state. So we very early on made the decision to prioritize residents of Central Falls because we have to get a handle on that situation. We've also provided vaccine to residents and staff of the correctional system, the prison here in Rhode Island and Cranston, understanding that they've had outbreaks, that they've had patients die there, et cetera. So we've tried to maintain equity here in Rhode Island. And I think one important thing to remember, right, is that every vaccine administered in Rhode Island, regardless of who gets it, is one step further to us achieving herd immunity and one step further to us achieving control of this pandemic. And I've said this before, but I'm really optimistic that that this is the light at the end of the tunnel. I do want to encourage people to be patient. Again, we're getting 14,000 doses a week. Sounds like a lot. Again, Rhode Island, 1.1 million people, allows us to vaccinate 1.5% of the population. Understanding that in phase one of our 4 phases here in Rhode Island, phase one alone, healthcare workers, healthcare settings, nursing homes, group homes, some other settings, is about 200,000 people. So it doesn't go a long way, and I'm going to talk about that in 1 second. I did want to acknowledge the vaccine subcommittee here in Rhode Island. Thank you again to Dr. LaPlante. This is widely available online, but a great group of scientists, physicians, pharmacists, other community representatives who are providing insight as we talk about both prioritization and safety. And this is my last slide here, but really the big challenges in Rhode Island have been a limited vaccine supply, right? If I had to wave my magic wand, certainly we would provide vaccine to everyone, and that is our ultimate goal, but it's been tough. The second, close second to this is prioritization. I know we're going to talk a little bit more about this, but it's essentially, I'll say here at the Department of Health, we're doing our best. There's a lot of tough decisions to make. It's a bit of a no-win situation, to be honest. I think for so many groups, you can make a case of why they should get the vaccine first. Curious to hear what the other panel members say. The way that we've approached this is to try to get input from everyone and frankly, do the best we can, understanding that we can't get to everyone at once. So I do want to thank everyone for their patience. I am optimistic that things will get better that as the manufacturing processes increase, both with Pfizer and Moderna, that we'll have more vaccine. And also there's 2 other vaccines on the horizon, including the Johnson & Johnson vaccine and AstraZeneca. So I am optimistic that things will get better. Thirdly, lack of communication. As I sort of mentioned, we've, one classic example of this is last week we were told we're going to get more vaccine, right, from the federal government. They were going to come in, the Biden administration was going to come in, release all their vaccine. Come to find out, they actually didn't have any in storage. So that just makes it really, really, really difficult to plan. Also, we didn't know the timeline for when the Pfizer, the Moderna vaccine were going to be approved. So this whole timeline and using vaccines as an example, but frankly, it's been the entire pandemic. There's just been a lack of communication. It's made it difficult to plan. The logistics are complicated, et cetera. So lack of data. I'm sure there's some questions that are going to come up. How long does the vaccine prevent against infection? Does the vaccine prevent against infection versus disease? One thing to keep in mind is that when we hear these vaccines are 94, 95% effective, it's effective against disease, which is good. So if you get the vaccine, you won't get sick with COVID. You won't end up in the hospital or die. But we don't quite know yet whether or not they prevent against infection and being asymptomatic. And that's why we still recommend, even if you get the vaccine, that you should wear your mask, physically distance, et cetera. How long immunity lasts, we don't know. This is an ongoing question. What's the optimal dosing or dose for the vaccine? Some of you may be aware that there's been a lot of media coverage about, well, why can't we just give one dose? Why can't we cut a dose in half, et cetera? So these are all great questions, the questions that we don't know quite yet. And one thing that's really hampered our response is the lack of data. On the flip side, one thing that I've really been astounded about is just the accumulation of scientific data. And it's really amazing to me that the entire scientific world has come together to address this pandemic. And I mean, people, doctors, of course, and other scientists, but like behavioral scientists, modelers, mathematicians, statisticians, anthropologists, economists. I mean, it's really ridiculous how the, people from all over the world, all these disciplines have come together to solve different aspects of the pandemic. And it's like every day there's like 1,000 articles now being published. It's actually really tough to stay on top of the literature, but lots of data and more to come. And finally, misinformation and myths. And I think it's great that we're having this panel on the eve of our new presidency here. But there's been a lot of misinformation swirling. And I think that we see that harm certainly our vaccination efforts. But one of the saddest things about this really to me is just the fact that that there is so much information out there. And I think, we live in the United States of America, right? No one's going to force you to get a vaccine. And, at the end of the day, of course, I would strongly recommend it and hope you would, and we can chat through some of that. But at the end of the day, no one's going to force you to get it. But what I want people at least to do is to base their decisions on science and facts, and to understand the risks and the benefits and make a decision, and not on misinformation and myths out there, such as, does the vaccine, the vaccine causes infertility? It would make me sterile. It does not. That is not true, factually inaccurate. Does the vaccine alter my DNA? It does not. Does it cause COVID? No, it doesn't. It's only a small fragment of the viral genome that codes and leads to immune response. So these are all sources of misinformation. Again, encouraging people just to check out the Department of Health website, CDC website, or ask your physician or medical provider about some of this. So those are some of the minor challenges, just a couple of them. But thank you, Dr. LaPlante. Back to you.
Thank you, Dr. Chan. And clearly you are an expert at answering all these questions. You had them all ready to go. That's good. We'll be revisiting a few more in a bit. So, let's turn to Professor Hutchison to discuss vaccination hesitancy. So, to meet the goals that Dr. Chan spoke to, us here in Rhode Island, we need to get vaccinated when the vaccine becomes available for us. And we're going to get to the prioritization in a bit. A significant portion of people report being unsure if they will sign up to be vaccinated. And of interest, there was a recent article in the New York Times noting that up to 40% of healthcare workers have concerns or do not want to get the vaccine. So, it makes you wonder, is there a right to refusal to participate? Does this harm affect other people? Professor Hutchison, can you help us understand what seems to be an unexpected response to the vaccine that can protect us from a deadly illness? And also, do you have concerns that, with these healthcare professionals that are not wanting to get vaccinated? Is that anti-vaxxer propaganda? What kind of message does this send? Is there a lack of trust, and what can we do about it?
These are a lot of great questions, Carrie, and I appreciate it. Thank you for having me on. Going back to your idea of the right to refuse, it's almost, I want to kick that down to Cheryl at some point, who's the philosopher, because it really raises a sort of a moral philosophy question in some ways, right? It's very similar to the anti-mask arguments that they make that's framed around the civil liberty, regardless of what position you're in. And I seem to remember these kind of debates after 9/11, security versus freedom, only this time it's kind of a little bit reversed. But going back to your point about the 40% New York healthcare workers sort of opting out, being hesitant, that's not all. I mean, consider some of these numbers. I did a lot of reviews just kind of looking anecdotally, and it was like 30% of Orange County healthcare employees, 50% of Riverside, California County, 50% of critical care nurses in the Houston hospital, 40% in the Chicago hospital. And then the New York Times article that another New York Times article we're looking at was 60% of Ohio nursing home workers. And that's really frightening given the fact that about 40% of deaths have been linked to nursing homes. Even here in Rhode Island, 2 days ago, Go Local Providence reported about a third of nursing home workers were opting out or being hesitant about being vaccinated. So this hesitancy is kind of it's really an endemic problem, and it threatens recovery from the pandemic. But this problem is actually not new. Distrust and hesitancy in vaccines is actually significantly increased over time. Carrie mentioned the research that she and I have done in the past. Our research team in 2017, we conducted a series of surveys about another vaccine largely targeted towards adults. So even 3 years ago, we were running surveys trying to figure out and dig deeper into these attitudinal barriers against vaccines. And in those studies, we're really concerned about some of the major racial and ethnic disparities in vaccine rates, so that even if you account for the difference in access, right? So everybody has access, you would still see these major differences, particularly among Black and Hispanic populations compared to whites. So when we did these surveys, we were looking at, well, how much hesitancy do we have for vaccines even then? And we found, if anything, there was even a little bit more hesitancy. About 40% of our respondents were not likely to get a vaccine, even if it was free. And so we dug a little bit deeper and we wanted to look at, well, where is this coming from? Where are the pockets of resistance? And what we found is that we sort of identified 4 main pockets of what I call hesitancy. First, among Black Americans. Second, among, we consider a small sect of conservative religious objectors. A larger proportion of what we consider sort of conservative libertarians, sort of small government, no government, get off my back, the type of libertarian. And then sort of what we would consider highly liberal, almost naturalists. So this is a real challenge to explain because it doesn't really fit neatly into sort of these easy narratives of divides, red-blue divides, if you will. And not much has changed over the last 3 years. This is surprising given the current pandemic. I mean, in the last month, December 2020, the Kaiser Family Foundation showed that 30% of the population was hesitant. And the reasons why were very similar to what Dr. Chan was talking about: concerns over side effects, a strong distrust in government oversight that was ensuring vaccine safety. And even last month, they identified these sort of pockets of hesitancy: Black Americans, Republicans, people aged between 30 and 49, and those living in rural areas. Another similar study last month by Pew also found that less than 43% of Black Americans said they would definitely or probably get a vaccine. And this is a problem for 2 reasons. First, 65% of deaths from COVID have been centered in the Black and Hispanic communities. And second, frontline healthcare workers are predominantly Black and Hispanic. So again, this is kind of frightening, but if you've been paying attention to trends over time, it's not all that surprising. In the study of attitudes, which is where my area of expertise is, the research on vaccine attitudes have consistently revealed that hesitancy is usually not related to scientific knowledge, right? Like knowing that this is bad. And this is an assumption that's often made by well-intentioned practitioners in the public health field. And so it deepens the surprise that when we see these surveys, like so many frontline healthcare workers are resistant to vaccines. And this is what makes it such a vexing problem. Because opinions are different than facts, and a decision to get a vaccine is largely reflective of individual opinion. And so this becomes more of a cultural wedge issue, a cultural issue than anything else. And like, unfortunately, our politics, emotional appeals, anecdotes, these things are often more effective in appeals than sort of just straight facts or rational logic. Now, going back to our study, understanding this also gives us an advantage, some tools to be more effective. And when we did our study, we did an experiment. We did an experimental design where we randomly tried out different appeals on respondents and compared the likelihood of them being less hesitant to get a vaccine. So we looked at, well, will you get a vaccine, sort of the control. We did a factual, logical appeal. And then we did an appeal to family and duty, a real emotional appeal. And what we found is that respondents were significantly less hesitant to get a vaccine after hearing these appeals to family and duty, as opposed to other appeals. And in particular, we found the sort of strongest respondents amongst people and respondents of color. So while there is a lot of hesitancy about vaccines, there are also tools and strategies that I think we can use forward and we should think about as we go about combating the pandemic. So, and with that, I turn it over to you, Carrie.
Thank you, Mark. That was fantastic. I love the passion. And we spend a lot of time talking about trust and lack of trust. And we'll come back to a couple of those. So last, here in the question series, Professor Foster, so you have the hard job. You have to listen to what everyone says here. And you've been giving me great advice along the way, you know, from an ethics perspective on prioritization. So, you know, lots of hot topics here. As a philosopher, you have to consider the big questions built into the vaccine program design. You know, who should receive the vaccine first? What a question, right? Should vaccine programs be designed to prevent the spread of illness in the community or save the lives of those who are most vulnerable? Please share your thoughts with us. And you have the hard job of reframing this, but we're excited to hear.
Thank you, Carrie, and thank you, everybody, all my colleagues and friends who went before me. But I'm going to share in a moment a very brief infographic, because philosophy is a very abstract thing, and ethics as part of philosophy can be difficult for people to picture or get their minds around. And so I'm going to share an infographic in a moment and use it almost as a map of where we've been in this discussion so far, and pinpoint bits of what everyone has said to that map or to that chart. And before we get started, I just want to leap off from where we ended with Mark and the whole question of the right to refuse and health disparities in different communities, and the role between we in the academic community tend to overestimate the balance of science versus other values and ways that people share information. I think it's important also to honor historically the fact that there may be good reasons why, and I can't speak for the Black American community by any means, but why Black Americans might have hesitancy at times about new scientific studies and things. There are precedents with abuse from the science community and the medical community. And so this is why panels like this matter, because beginning with dialogue and also sort of honoring and acknowledging that perhaps it's not just marketing or folklore, that people may have historically grounded reasons to be hesitant. And in ethics, that's one of the things we do. We try to develop a responsiveness to people's understanding of the issue. And I know that this is something that Dr. Chan does every day in his job. When people express fear or hesitancy, his first response is, tell me about that. Let me understand that. I've heard him do that. And it's a wonderful thing. So what I'm going to do is just share this little, and apologies because my slide isn't nearly as nice as Dr. Chan's. But I want to share very, very briefly with you, when we talk about ethics or morality, these are interchangeable. What we really mean is, you know, what's the right thing to do? How can I be a good person? And ultimately, we talk about ethics as having three characteristics. That it's, you know, if you want to do something that's good or right, it has to be ultimate. In other words, the right thing to do ethically can't be trumped by prudence, self-interest, or pragmatic considerations. It's also supposed to be universal, that any reasonable person in this situation could and should do what we're about to do. And then finally, and perhaps most importantly for questions of equity, it treats the good of all alike. That certain people don't get into line ahead of others because they're in positions of power or influence, that everybody is treated alike, no matter their abilities, their constituencies, or their random natural and social contingencies. Being born poor or rich shouldn't matter, being born fully abled or being a person with a particular type of challenge or disability shouldn't matter. So the other thing to point out here, and I'm going to use my little pointer here, is a lot of times when we get into fights about right and wrong, what we're really fighting about is where we put the emphasis in this little equation. A person or an agent undertakes an act that has an outcome. And competing theories about right and wrong in ethics really come about because they put the emphasis in different places. And in a moment, I'm going to walk you through how everybody on our panel has punched on every single one of these different things in interesting ways. So folks who put the emphasis on outcomes are called consequentialists, and they think how we define right or good action is maximizing benefit and minimizing harm. And that's what constitutes the right thing to do. Did it maximize good? Did it minimize bad? Other folks put the emphasis on the act itself. Is the act doing your duty. And deontology is a fancy word. Deon in ancient Greek means duty. And these are kind of like, excuse my expression here, but the hard asses of ethics, right? So people who put the emphasis here want to say the right thing to do is right in and of itself, no matter what the outcomes, no matter what your intentions. You have to do the right thing rationally and consistently. And then finally, people who put the emphasis here, virtue ethicists, say what matters is being a good person with good intentions who behaves in a virtuous manner. Sometimes we make mistakes and the outcomes are bad. Sometimes we might break a rule or do something that generally is thought to be bad, but we intended to do good. So here's the other little thing I want to walk you through. And I've been furiously scribbling here, you probably noticed. But starting with Mark, we're gonna kind of work backwards and sideways here. Mark mentioned, we do, if you're a fully competent human adult, you have the right to refusal of any treatment, right? If you are otherwise competent and capable of self-legislation, you have the right to autonomy. Now, there are limits to autonomy, and this is what we say. Each of these theories here that I just showed you, consequentialism, deontology, and virtue ethics, comes with certain principles, and principles are just little maxims or rules for doing good in that way. So if you're a deontologist, you think the principle of autonomy matters and that we shouldn't interfere in people's autonomy without good reason. Of course, one good reason to interfere in autonomy, say, for example, fine people for not wearing masks in confined public spaces, is that they harm others. So that we're not free to do whatever we want whenever we want. Autonomy is not limitless. And one of the limits is the harm principle. When Andrea was talking about the history of vaccination, and she said, really, vaccination can work in two ways. We can look to contain the outbreak, but we can also work to eradicate. Containing the outbreak reduces what we call, bad things. Non-maleficence is the principle that says we should work to contain the harm. And so practically in a vaccination program such as the one we have now, we're working collectively to limit the harm of this disease that is taking the lives of so many. When we work proactively to eradicate a disease in science, we're actually working toward what we call beneficence, to maximize the benefit for the greatest number of people. So in consequentialist theory, people who put the emphasis on maximizing benefit for the greatest number of people are called utilitarians. And folks who put the emphasis on minimizing harm for every single person would be Hippocratic, from the medical Hippocratic Oath, focusing on each and every person, minimizing harm to them. So even historically, we can see that the aims of vaccination can meet principles of both limiting harm and maximizing benefit. Now, coming back to Phil and his excellent sort of overview of the very complex goals of the program as well as challenges, Dr. Chan hit every single principle. And I think this should give us faith in what we're doing here in Rhode Island in the approach to prioritization and thinking about eradication of COVID. And how did he do that? Well, this is complicated, but bear with me. Obviously, in emphasizing safety, we want to minimize harm. So that's an outcome-oriented thing. We also, he said, want to limit morbidity. That's another principle within deontology. In medical ethics and health ethics, we want to avoid killing people. And that's a principle that should guide our actions. And therefore, in limiting morbidity, what we're doing is avoiding death. And that's an ethically important thing. We're also going to try to be efficiency. Why? Well, we want to be efficient because we want to maximize the number of people who benefit from this in the shortest time possible, as long as we hit safety. In other words, limiting harm. And then something close to my heart is what we say about access. Access aligns with the principle of justice, fairness, that everyone ought to have a fair chance at getting the vaccination. Now, the difficulty when we fight about fairness is that fairness can be defined 3 different ways. Is fairness that everybody gets exactly the same? Should we, for example, as Dr. Joss says, have a lottery? Everyone has an equal chance? Should we just say, well, we should give the vaccination to people who are most likely to use it and be compliant, make the most effort? But the third way is the one that Dr. Chan himself mentions, which is equity. And equity tends to focus on people who need the vaccination most, that we give the resources as a priority to those who need it most. So Carrie, when you asked the questions at the beginning, who should be first? How should we allocate? Some of what we hear is utilitarian. We want to benefit the most people, right? But some of what we emphasize is in this category of justice. We want to make sure that people who are most vulnerable, whether because they're frontline workers who can't work from home or because they have a risk condition, and that's equity. Now, this links to the final thing I want to say about this, which is the challenges that Dr. Chan brought up in the prioritization and vaccination program. Misinformation relates to the principle of veracity or truth, that we have an obligation as public health professionals to tell the truth. However, because this is a new disease, because we still don't have tons of data, we're always going to be working with a certain degree of uncertainty. And this is inherent in science itself. No amount of data guarantees that the next person who takes the vaccination will react the way everybody else did. I'll give you an example. I'm allergic to codeine, but I didn't know this until I went into the hospital for wrist surgery, and I was given codeine after my operation and had a major anaphylactic reaction. Codeine has been tested. Most people can take it safely. But that data doesn't guarantee that the next person will. Does that mean we shouldn't do it? No, not necessarily, because any scientific information is subject to revision and refinement. And so when Dr. Chan says we just don't know yet about all the data, that's true. But does it mean we don't know that the vaccination is safe? No, because it has been subjected to the process that every other medical treatment has to go through, including codeine. It's no guarantee, but the data so far is on our side with this. It does mean, however, we have to collect honest data, which is veracity. And then the final thing I'll offer to before we go into our discussion is the notion of inclusion. This is happening locally and globally. Locally, Dr. Chan says we've invited lots of people to the table. Carrie's part of that table. We're trying to get everybody involved in the discussion so that all perspectives get brought. And globally, we're all working together to eradicate. But the final theory in ethics is perhaps the one that matters most. That in order for us to trust that the process is working, that we can put ourselves in the hands of our hardworking, sleep-deprived scientists and medical professionals, we have to trust that people are acting virtuously and with good intention. And so when we act locally and globally to eradicate disease, to have a safe vaccination with the best data in the most just and fair way that respects autonomy, but promotes truth, we act with fidelity or loyalty to each other as human beings. And finally, what we do is have good intentions and bring all of these other principles to bear on how we approach it. So to finish, Carrie, when you said, what should we do? I would never answer that question, but what I would invite everyone tonight who's with us to think about is sometimes what we should do is maximize benefit and minimize harm, but we don't want to lose sight of perhaps justice and equity, which addresses the most vulnerable as priorities, while also acknowledging historically that people's hesitations for trust and fidelity are based in the data of the past. How do we overcome that? By being virtuous in the present. Thank you.
Thank you, Professor Foster. That was fantastic. We've had a lot of conversations this week, and what I learned most from you through these conversations is that these are all different frameworks of approaches. Do we go and vaccinate all of the persons in the grocery stores because they've been open since the beginning of time and they have, face-to-face contact? What about our teachers and our educators? That's in front of our students and our children need to be back in school. What about our most vulnerable? A good society protects the vulnerable. older age and high risk. It's as Phil said, Dr. Chan said, it's an impossible situation, especially when we're only getting 14,000 vaccines a week. But I totally appreciate that perspective. I'm going to switch a little bit and go to some of the questions that are coming in from our community here. And one question, that I've been getting to, and I'm going to pose this first to Dr. Chan, is, you may have heard about the Moderna vaccine. A lot number has been pulled out in California. We've also been hearing, I think in Norway, there were 29 deaths. There was a doctor in Florida and a nurse in Portugal, all had reported deaths. I don't know, after the COVID vaccine. What do you know about that? And, without knowing the intricate details, how can you respond?
Yeah, it's a great question. And I think, number one, it shows that our safety system worldwide, and frankly in the US, is working. Again, I've said this before, but no vaccine has been more scrutinized than the COVID vaccine, I'm guessing. But I'm reassured. I think one thing that we look at, right, as we scientists, public health, clinicians, we look for signals and things unusual. So as you mentioned, Dr. LaPlante, right, when 20-something folks die after getting the vaccine in Norway, that's a pretty big signal. When a dozen people have anaphylaxis, allergic reaction in California after receiving one lot of a vaccine, that's an issue that rises to the top. That's a signal. Again, I'm reassured, right, that we have vaccinated millions of people with Moderna here in the United States, and this is what we're hearing about. We're hearing about isolated, random incidents. And when I hear these stories, I become a little bit skeptical that there's something else going on, right? So you have to imagine, we have prioritized nursing home residents here in the United States for vaccine. It's hard for me to imagine that Norway would have seen something that we haven't seen in the United States yet. So it tells me that there's something else going on, that there was either another nefarious purpose, that there was something wrong with the batch, it was contaminated or something like that. So that's where my mind goes to first. And I think the fact that we recognized this early, that at least in California, right, that the vaccine lots were pulled, it shows me that people are watching, that the system is working. And of course, it's terrible that people had adverse events. People in Norway died, but I think there's going to be more information to come. And I got the vaccine myself a couple of weeks ago as a healthcare provider through my hospital system, and try to live by example. But I wouldn't be concerned as a general person, and I'm not concerned personally about getting my second dose of the Moderna vaccine.
Excellent. Thank you, Dr. Chan. I'm going to kind of open this question up to the panelists, see who wants to take it. So, we hear a lot, even on campus or at different hospital settings, that vaccination should be mandatory. If you're going to be a healthcare worker and you're going to practice and you're going to take a paycheck, you should be, mandated to take this vaccine. Any past experience in mandatory vaccinations, how has it panned out? And, maybe Professor Hutchison here, from a sense of trust, how do you change people's mindset and get buy-in for them to do something like this?
Well, that's a great question. One of the things that's interesting about vaccines is that because there's government oversight over the approval of the process, it is oftentimes linked to trust in government, even if the government is not mandating that vaccines be put forward. And that's why we've always seen this kind of pretty strong relationship between trust in government and sort of, I guess, the inverse relationship between trust in government and sort of hesitancy towards getting different vaccines. But the question here isn't, it's an interesting question because it's something that we've been wrestling with for a while. And maybe Andrea can give us a little bit of historical about mandatory vaccine campaigns in the past. But what we're seeing right now is there's going to be a real hesitancy by the government, I think, to make mandatory for these vaccines. But private organizations absolutely make conditions on employment all the time. And we're already starting to see, it's interesting, I was reading a couple articles earlier today about companies offering big incentives to their employees to get vaccinated, like $500 bonuses and things of that nature. That's one way to do it. There's also sort of a punitive way to do it. And I think there will come a point where if there is so much hesitancy to get a vaccine in an area like healthcare or something like that, where it's really critical that people trust that their, let's say their older parent or something like that is going to be safe. I actually do think that we'll start to see it spread out, but I don't think it's going to come from a central. I think like many other things, it's probably going to come more sporadic through different companies, and they absolutely are going to be able to do that because they do stuff like that all the time. This is why you can get fired for going to a Capitol rally. They have a lot of control over that. So.
Yeah, posting on social media, anything. Yeah, great point. Andrea, do you want to comment on that?
Yeah, I'll just say a couple of things. In England, smallpox vaccination was made compulsory in 1853, and it occasioned quite a bit of opposition from the public. And then the early roots of anti-vaccination movements stem from that. And the English reformed their laws in the late 1890s to allow individuals to request exemptions, much as we do today regarding vaccine policies for going to school for your children. So what historically making it compulsory does not work as well as education and other types of methods but approaches to make people understand the benefits of vaccination, including all of the ethical issues that Dr. Foster raised in her presentation, and Dr. Hutchison as well. But I think Dr. Hutchison's point is exactly right. We can look at different entities within society that have made vaccination a requirement in order to participate. And that is certainly an issue right now. I know in the past, I think healthcare workers were given alternative assignments if they did not get a vaccination. I think that's correct. But right now, that's very difficult because our healthcare system is so strained that's going to make that a more difficult type of arrangement. So.
That's a good point, Andrea, that I've seen exactly that. You won't be patient facing. Yeah. Cheryl, do you want to comment on anything?
Well, again, I'm going to sort of back into the more abstract thing briefly, but when we talk about your right to refuse, right? I think Andrea is spot on about this, that historically and also even ethically, making certain things mandatory has to be undertaken with great caution for lots of reasons, especially in the United States, where part of our entire cultural identity is rugged individualism. There's a lot of myth to that, but it's powerful. What are some of the reasons we say we can limit autonomy, right, ethically? And the two big ones that come to mind beyond the obvious is we don't yet have substantial or psychological competence, right? That minors, folks with intellectual disabilities may not have complete functional, legal, or ethical autonomy, people in comas. However, beyond that, we have the harm principle that I mentioned earlier, which is if we know that you are harming anyone by a refusal of something, then there is sometimes a right of people collectively and civically. I'm thinking in some states, motorcycle helmets, right? Helmet laws are there not just for paternalistic reasons to protect people from themselves, but also because of the social cost of accidents and people not wearing helmets. And therefore, if it's deemed to be sufficiently and collectively harmful to the population, then democratically, that is one legitimate limit on autonomy. And the other one is a little more difficult. It's more diffuse. It's the idea that if everybody or a substantial number of people refuse, what's the diffuse harm to others? And that's where we're at with the vaccination, because we don't know what we need to reach a certain point where we limit that harm at this point. But those would be two reasons not to make it mandatory at this particular moment.
Thank you for that, Cheryl. Another question that came in, I can take it, it's pretty easy. Is there a certain weight-based dose for the vaccine? And no, for adults, they all get the same dose, whether you get Pfizer or Moderna, that is consistent. The only thing that changes is the needle size. So, so a 120-pound person versus a 250-pound person, they are getting the same dose. And that's what's been tested in clinical studies. Big question for you, Dr. Chan. You know, I think the biggest question all on our minds, and I know I'm calculating it, like, when is life going to be back to normal, right? I do the math on the vaccine, 14,000 a week with Johnson & Johnson and AZ coming out. September, what about June? Like, when? I know this is an impossible question to answer, but, you know, give us your perspective on when life, if life can return back to normal.
So I'm going to be optimistic. I'm going to say, and I think we observed this in 2020. By the way, 2020 is done. I'm happy about it. But, you know, with a lot of these epidemics, we see peaks and valleys. And what we saw in 2020 was basically that things sort of bottomed out in the summer. And that's natural, I think, as a lot of us know, for things like the flu, for respiratory infections. So I am optimistic that we will have some degree of normalcy by the summer and be potentially back to normal by the fall. And part of what has me saying that, of course, is things, you know, these infections are transmitted less during the summer, and we have vaccinations. So by the summer, a large subset of the population should be vaccinated. And also in parallel to that, a large percent of the population, a significant percent of the population has already had infection, sadly. But that's also going to lead and add to herd immunity. So I'm optimistic by the summer we'll have some degree, hopefully a larger degree of normalcy. And I think by the fall, knock on wood, things will be back to normal.
I'd like to answer. We did not discuss this, but I've been saying similar. So I'm an optimist. So that's been fantastic. Great. You know, I'll send one more question back to you, Dr. Chan. Questions I get a lot about the variant. I don't prefer to be called the more virulent COVID, SARS-CoV-2, but the variant. You know, is that covered by the vaccine, and that to our knowledge? And do you have concerns for this variant that we're starting to see?
Yeah, thank you, Carrie. I think you kind of hit one of the larger unknowns on the head. And I think all things considered, I think the vaccine would end the pandemic. And I sort of hesitate there just for a second because, you know, the variants that we've seen so far, so there's this B.1.1.7 that's emerged in the UK. There's some data that suggests it's 50% more likely to be transmitted. There are variants emerging that appear to be more easily transmitted, which makes sense, right? In the history of virus evolution, what's going to happen is you're going to have these variants that arise that spread more easily through the population. Now, the good news is that Pfizer and some other preliminary studies have indicated that the vaccines out should be, knock on wood again, effective against these emerging variants. What gives me pause, though, is that there are some variants, a very, very small number, and there may be more, that are recognized as being slightly resistant to the vaccine. And so that's a problem. So as Dr. Fauci has put it and others have put it, we're in a race against time. Can we vaccinate enough people? Can we achieve herd immunity before some of these variants may become more prominent? The one bright note I will say is that, especially with the RNA vaccines, is that they can be easily tweaked and edited and manufactured. So even if we do see a variant, again, the bright light would be that these vaccines can be easily adapted to address these variants. So good news. I'm going to stay optimistic. I really hope it's one and done with this vaccine. I'm more than 50%. One and done, and we're there. We'll see.
I like your answer there. Cheryl, anything you wanted to add? You were leaning in before I jump. We have a couple minutes left.
I just wondered if anyone on the panel, and Andrea, this may be more in your wheelhouse, but sees any parallels right now in terms of the issues that Mark raised about trust about the government in the vaccination. I'm thinking about, I have daughters. So a decade ago, should I get the HPV vaccination, right? I remember the resistance to that. I remember as a child waiting in line to get I'm old enough to get the polio drink. It was a drink back in the day, in the early years. And then just resistance to other vaccinations that turn out to be very good for public health. And of course, the MMR continues to be a controversial one. Are there any parallels or differences in resistance now to resistance in the past?
I think some of the factors that Dr. Hutchison mentioned have a long history, especially within the United States. So particularly the finding regarding Black communities being suspicious of the vaccines comes from, as several of us have noted, the historical discrimination that Black communities have faced. A second thing is this libertarian streak within the United States in particular, which has sort of thrived in criticisms about vaccination policy. And the sort of growing, I saw that there was another question about misinformation about vaccines, that the role that social media has played in allowing many types of misinformation and false information to be propagated within the United States more generally. And that's just been building since the MMR controversy erupted in the late 1990s. With the purported link between autism and that vaccine, which has been disproved multiple times by different types of scientists and medical researchers. So it's there's a long-standing trend, and it's something that I think we really need to address to make sure that people do understand the benefits of vaccination.
Can I also ask anybody on our panel, and I suppose, Dr. Chen, this is also directed at something you had said, that we're trying to bring everyone to be inclusive at the table of discussing prioritization. To what extent is cultural competence and respect for each other within society a priority or a factor in how we're going to, work together towards understanding the vaccination as a whole in our society?
Well, thank you for that. I mean, I think one thing that we've seen, and I hate to make any political comments, but one thing that we've seen is that our nation is quite divided. And I think for me, at least as a physician, as a scientist, is that I'm always open to learning more and additional questions and to discussing topics. And I think we all have to be, with the caveat that we have to do it in a respectful way, respect to each other. I think that's one thing that makes our country great. And I really do believe that, is that we are everyone has ideas, and we should be sharing those. And that's how we promote great science. It's how we promote our great country in general. And I really do believe that. But the heart of that is that we do have to be respectful. We have to be, agree to disagree, and also respect everyone's backgrounds. And I try to do that myself. And I think that that's really what's needed, frankly, whether or not we're talking about vaccines or anything else out there. I try to live by example and just encourage people as we talk about some of these tough topics, whether it be vaccine hesitancy or politics or whatever, just encourage people to kind of do so out of a spirit of respect for each other. And really, at the end of the day, right, everyone wants this pandemic to go away. I would hope so. So we're all trying to get to the same place. I think we have to all recognize that. Occasionally, we may disagree on how to get there. But again, at the end of the day, we got to be respectful and listen.
I'm going to go over maybe 2-3 more minutes because we have a couple good questions coming in, and one for Dr. Chan. When will the limits on travel stop? When can we get back to traveling to other states and even internationally?
It's a great question. Lessons learned, I actually don't think that we clamped down on travel enough early in the pandemic. And there's been some initial, review of what could have been done better and earlier on. I think in terms of traveling, I don't think there's an easy answer. I think it depends on what goes on in the rest of the world. As sort of an ethics, if we could talk about all day about vaccine implementation, dissemination, distribution in developing countries, and how the Western world, resource-rich countries are being prioritized for the vaccine. But also remember, again, that our ability to get vaccine to some resource-limited settings is going to also affect us here in the United States, Western Europe, et cetera. So hopefully travel will open up again by the summer. I do foresee that countries are going to require vaccination cards that are being given out, et cetera. It'll be interesting to see. I think a lot of us are obviously had a tough year because of the pandemic. And I think there's going to be many people that are a little bit reluctant to travel, understandably. So hopefully things will start to open up slowly. I know for myself, I used to travel like twice a month, and I haven't flown on a plane in over a year now, actually, which is kind of weird to think about. So more to come on that.
Is great. So we are wrapping up. What I'm going to do is give our panelists the final word. I'm just going to go around the room in the same order we started, asking everyone to just give their one line, one statement, any wish or final comments that you want to share with our community. And Andrea, you're first. Any final?
Final thoughts. I just want to thank everyone. This has been a very illuminating conversation, and I think it is important to raise these important ethical and political and historical questions that can help us make sense of this current pandemic and give us ways to try to understand the tragedies that many of us have experienced.
Thank you, Dr. Chan.
Yeah, thank you again, Carrie, for moderating, URI, Elizabeth Roberts for hosting. I just want to again encourage folks listening for patience and flexibility as we kind of work our way to getting all of Rhode Island vaccinated. And always feel free to contact us at the Department of Health. We're always open to suggestions, critique. Again, please try to do so in a respectful nature. We are open to feedback, et cetera. But just thank you, everyone. We're in this together. We're getting there. I am optimistic that we'll be there soon.
Thank you. Mark.
I will be a broken record. I want to thank everyone. It's been a great, wonderful panel. You know, I've learned so much even just sitting here, and I just want to thank Barbara and Elizabeth and Ian who are working in the background as well. These are important conversations to have, and I did want to reiterate, you know, something that Dr. Chan and Andrea referenced earlier. You know, unfortunately, vaccines have been politicized, and I do political science, so I'm always going to come back to this. But there are ways to do this, and there was ways not to. And I think the attitude, the flexibility, the openness, the understanding of others is really the way to go. We know this. Like, you lecture at people, they're going to shut down. You talk to people, you try to find the common humanity. What do we owe each other? What are we doing? This is effective, and this is what our research says. This is what feels right. And you know, I just want to encourage everybody to kind of really think about that as we move forward and combat this pandemic.
Thank you. And Cheryl.
Ditto thank you to everyone on the team and everyone who attended and joined us tonight. I just want to say thank you to all the hardworking scientists and healthcare workers, also custodial staffs everywhere who've kept our surfaces clean, our public transport drivers, our teachers and educators, anyone who has taken personal risks for the greater good during this difficult time. As Dr. Chan says, we're all in this together. Thank you for your humanity and courage and bravery. Those are virtues.
Thank you, Cheryl. To our panelists, thank you so very much. To Barbara and Elizabeth and Ian, thank you for making this happen behind the scenes. And with that, I'm wishing everyone a great evening. Be safe. Thank you.
Thank you.
There's Ian. Ian, thank you.
You're welcome. That was good. And our attendees are leaving, and the Facebook stream is ended.
How many views did we have on Facebook? Since that's what all of life now comes down to.
So I wasn't monitoring that. Patrick was monitoring Facebook. At peak on the webinar, we had 116 people.
Great.
Well,
And
since Facebook
Elizabeth,
people say they're coming and they're not, to get that many
yep,
Yeah.
when people signed up is really great. Well, good job, organizers. That's a good yield.
I'm getting a lot of texts, obviously from friends, but but Elizabeth, you were muted. Were you going to say something?
and she's still muted.
No, I was just writing to Patrick to see, because he's monitoring Facebook to see if he has a number for us. And there was one other thing that's just gone out of my mind, so I'll think of it.
Great. Thank you guys so much.
Ian, is there someplace, Eli Sherman from Channel 12 asked me if there's someplace he was not able to get on in time. Is there someplace it's available recorded or not for a few days?
So it will be on the Facebook
Oh, he can go on
regarding,
Facebook?
Yeah.
Okay. Okay. Is that on the AHC website?
it's on the
the
AHC
Facebook?
website, the College
Okay.
of Pharmacy, College of Nursing,
Uh,
College of Health Sciences. We hit
All,
everywhere.
all of the Facebook pages? Great.
Yep.
Okay. I will let him know.
Everyone did great.
Thank
was
you,
nice.
everyone. It was very interesting.
It was very interesting. Thank you.
It was a great panel.
Yeah.
Yeah, and I want to thank my co-panelists there. I mean, I didn't realize we actually had such a wealth of experience on some of these topics. So obviously, if any of you ever at any point, honestly, feel like we could improve stuff that we're doing on the state level, definitely feel free to shoot me an email, reach out to Carrie. She knows how to get a hold of me. But I would, lessons learned from the past. I mean, I was, from the historical side, from the ethical side, these are things that I don't know much about, to be honest. I know a bunch about clinical care, public health, et cetera, but any lessons or any feedback you ever have for us on the state level, please feel free to share. We're always trying to
Literally hit every good thing. When I'm not just trying to make you feel good. I know this is a team effort, but when you put up those goals and challenges, every single ethical principle or virtue was touched upon in what you said. And in fact, same thing with Andrea and Mark. I mean, the hard thing was to limit it to a short period of time, but I don't think you could have done anything better, because literally from every ethical point of view, the way you communicated that spoke to something to everybody's ethical views. It was amazing, actually.
Well, thank you. I don't take credit for a second for coming up with that. I did not come up with that. Again, it was a group that did. But I will say, though, the one thing we struggled with is, I do feel, I get emails all day about school teachers who want to get vaccinated, about, current thing is about folks over 65 years of age. So there's a lot of unhappy people out there, and I get it. I understand it, and I want to vaccinate them. We all want to, but we can't. And it's frustrating at times because I don't know if our message isn't getting through. If it's just frustrated people and that's just the way it is, or if there's anything else that we can do to either streamline the process or prioritize differently. So I'm sure. Yep.
I'm just scared.
Yeah.
And as
And
Andrea said, loss too, right?
And it's difficult because each state has its own plan and parameters. And so, if you call up your relative in Florida and it's anyone over 65,
Got their appointment.
you
Yeah.
got the appointment. Yeah.
And
So
you
that makes it very difficult, I think.
don't
Yeah.
understand data. They
So,
don't. And so
I'll
anecdotes always rule. And if
Yep.
you live in your own social media bubble, you're just going to live anecdote land. I mean, you go back even to that Wakefield study, it was 12 people. The whole thing with the autism link was a study of 12 people.
Yeah.
Exactly.
So it's, I mean, I don't envy you guys at all, because it's hard to communicate. That's the one thing that we know is that, and it's not that people are scared. I mean, they understand an anecdote. They might not understand statistics. So when you say 28 people died in Norway, but that tells you something else, well, 28 people died in Norway, and that's what they're hearing, and they're not understanding oftentimes the big picture. And so, good luck to you. So.
Well, science, I always tell this to my students, logic is always trumped by rhetoric. And in the academy, especially, we tend to overthink, like we think, okay, we'll give people the data and they'll understand. But Mark, you're saying the stories. I think that scientists and policy officials are beginning to realize that the narrative arc is more powerful. That's why I asked about cultural competence, because stories are the coin of the realm in social circles.
And in social media, because again, it's a recursive cycle here.
So here's our reporting on the Facebook participation. It says we average about 14 to 18 people at a time consistently through most of the presentation. Facebook is showing about 1,200 viewers so far. I don't know how those two things match up.
Wow.
There's some funny math with that.
So, and we do post this in a couple of days, and I guess you can see it on Facebook now, but also in a couple of days, it'll be on the University of Rhode Island website as well.
Great.
Cool.
Great.
I just can't thank you all enough. First of all, you were so generous with your thanks to us all, but it was just that this was the most conversational one we've had, which was interesting because I thought it might be the least. And Carrie, I give you a lot of credit, but also the group, you just
Yes, great group.
interacted really well. Thank you.
Can I just add to that? This was, we talked about this being an interdisciplinary event, and I work a lot to promote interprofessionalism, the idea of learning with, from, and about each other. And I really think your comments reinforce that this really did become interprofessional. Mark, you talked about learning things you hadn't known before. And I think it was such a great example of the power of bringing folks from different departments, but under the same roof together. And Dr. Chen, we have to make you an honorary RAM because of this. People might mistake you as being, part of URI, and you're in our hearts because you guys really did demonstrate how, I think how beautifully the departments at URI, which is one of our missions, more interdisciplinary work. So I thank you for being able to open it up beyond sort of that clinical healthcare perspective. And I'd love to expand the conversation, thinking of, you were talking about the cultural issues. I have a friend in Sweden who I was talking to the summer before the vaccine, and they're much more of a collective society than we are. And they followed the rules because it was the right thing to do for people. And she couldn't understand here in the US why, people were so focused on their individual freedom. And so I think that speaks, Cheryl, particularly your talk about beneficence and virtue and, just doing the right thing because it's the right thing to do for people. So, thank you all so much.
Thanks so much.
Well, thank you. A pleasure to spend the time with you all.
Yes, and
Great.
thanks again, Carrie, for all the time you spent with us as well, one-on-one.
Good. This was great. Thank you all. Have a
Thank
good
you.
night.
Hey, and good luck.
Carrie, you
Good
were
night.
awesome.
Okay.
Thanks.
Carrie, I see
Thank you,
that.
Carrie.
I see that hand in your bag, Carrie.
My dinner's waiting. My husband's like, dinner's ready.
Yes.
Mine's waiting too.
All right,
Bye-bye.
everyone, be well.
Bye-bye.
Thank you. Bye-bye.
Good night.
Bye. Thanks, guys.